And our next talk, we know from one challenging to the other challenging. Chronic total occlusion, we come across very often with them. Almost 20% of PCI that we coronary angiograms that we see in our cath labs are chronically occluded vessels. And the most gratifying things for those patients where we do successful optimal PCI for symptom relief, although mortality benefit is not there, we all know. And for such complex area, our speaker has come all the way from US, Dr. Salman Arain. He is legend in the field. He is master. We all intervention cardiologists, I think I can see that we are on one forum, and we've already learned a lot from him. And Salman Arain is going to make his talk on chronic total occlusion. And I'm just giving you a confession over here. I personally, when we talk of bifurcating lesion, jail balloon technique, I did the first thing through here, Salman Arain's teaching, and after that, many cases have gone well. So, sadqa jariya patients ke liye bhi, hama operators ke liye bhi. So, welcome Salman Arain, sir, for your talks.
Assalamu alaikum, everyone. Thank you very much for having me here. It's an honor. This is my first Pakistan Live. I have 2 videos. Let's see if they play or not. But anyway, so CTO toolkit in 2023. So, those of you know me that know that my interest is in coronary total occlusions. I also do a lot of peripheral arterial disease. And so CTOs is something I've been dealing with for about a decade now or more. So I thought we could talk about the CTO toolkit. And then it's going to be a fast talk because I thought we had about 10 minutes. I don't see the timer, but I'll just get going. All right, okay. So the requisites for a successful CTO intervention include the proper tools, appropriate skill set and experience, and a well thought out strategy, which includes appropriate patient selection. And many of these things come with time. And there's a slide about how you can become a good CTO operator. But it all starts off by having the proper tools. If you don't have the tools, you won't be able to do a good case. Any CTO PCI or any PCI, or in fact, any endovascular procedure can be divided into 3 phases. Phase 1 is where you cross the lesion, the occlusion, the stenosis, the whatever you want to do. Then there's vessel preparation, and then there's actual definitive treatment. You can even apply this for valves, right? You cross the valve, you prep the valve, then you treat the valve. So for CTOs, you have to cross the CTO, either antegrade or retrograde. You have to prepare the vessel appropriately. Atherectomy sometimes plays a role in that. And then you have to do definitive treatment. Now, for us in the US, the definitive treatment is DES, though in other places, DCB may be an option. So the strategy of the procedure then determines the choice of tools. So you have tools for crossing, and these include the wires, the microcatheters, and your re-entry devices. You have tools for vessel preparation. This includes balloons, atherectomy devices, intravascular lithotripsy. You have tools for definitive therapy, such as DCBs and stents. And then you have adjunctive tools for imaging and support devices, and many other tools that we'll talk about. So in this talk, we'll just focus on perhaps the first and the second, the tools for crossing, because I think that's one of the most rate-limiting step for most CTOs. And inshallah, there'll be other talks on some of the other aspects. So let's start with wires. Wires are the essence of any intervention. So we cannot do intervention without wires, at least in this day and age. Wire selection for CTO depends on the CTO PCI technique, and in the days to come, inshallah, we'll talk about different techniques, whether you go antegrade, retrograde, wire escalation, subintimal, and there are wires for each one of those purposes. During a CTO case, the wires perform different functions, and because the wires are specifically designed for that function, a CTO often requires multiple wires because each wire is designed to do it. So you don't have one wire that does everything. So some of the functions that wires are used to perform: cap penetration, tracking either within the plaque or just outside the plaque. What we used to call the subintimal space is now the extra plaque space. Septal or epicardial crossing, knuckling, and re-entry. So all of these are different features of the CTO intervention, and they require different wires. And that's why it often requires several interchanges. All right. So what are some of the important wire properties? We talk about torqueability. This is the ability of the shaft to overcome the turning resistance. Trackability, ability of the wire to track along the vessel. Obviously, with CTO, it's much more sort of mixed pathology. You have some calcifications, you have chronic thrombus, some fibrin. Tip load, amount of force it takes to buckle the tip. Obviously, when you're trying to penetrate the cap, you need high tip load. Wire support, which is determined by the thickness of the core materials. Once you cross the CTO, you need a supportive wire to get the second or the tertiary gear down, and then tactile feedback. So many times in CTOs, it's very hard to feel what's happening, and you have to kind of visually see that. But having said that, you have to be aware that if you push too hard, the wire can go out the side. Okay, so I'm going to speed up a bit now just in the interest of time. So what makes a CTO wire special? There are 3 C's of any wire. There's a core, there's a coil, and then there's a coating. These are 3 of my sort of favorite wires. I'll give you my personal list in a second. But you've got the Gladius Mongo or the Gladius MG. That you can see the tip load is 3 grams. It's stainless steel. Below that is the Fielder XT. It's hydrophilic. It's got a jacket. It's got a slightly different tip, as you can see, stainless steel. Also, but much lower tip load. And then Asahi second, which we use quite a bit, which is 3.5 grams. And interestingly, this has special features. It's got a sort of a cone, a nose cone tip. It's pre-shaped. And it's got a sort of, even though the wire seems like one unit in your hand, it's actually wires within wires. The technology is amazing. So you can see how even the Asahi has multiple wires inside the wire that make it do what it does. So this is my selection, and again, you can either take a picture or I can share the slides later on. For microchannel probing, I typically go, my first choice is Fielder XT. I'll use a Xeon Black. If not, cap penetration, Gaia 2 or second. Intra-plaque navigation, typical Gaia 2, I think. Extra plaque navigation is usually Mongo, though this is something new for me. In the previous year, I was using a Fielder XT. For knuckling, I think Mongo makes the best small knuckles. If you want to make a bigger knuckle, you can use the Fielder XT. Septal surfing is Scion Black. Epicardial crossing is Suo. And reentry is CP12, the Confianza Pro Hornet. Now, there are a lot of names here, but if you actually see, there are about 6 wires that I use. So within 6 wires, I can do pretty much most of my CTOs. There are some alternatives. Sometimes I use that to sort of teach myself and teach my fellows, but anyone should be able to do most of their CTO cases within 6 wires. All right, but wires alone don't do the trick. You need something else. You need microcatheters. Microcatheters, again, you have different brands available. They're essential for CTO. They're also very specific microcatheters. There are several advantages over the wire balloons. They have greater flexibility. They're torqueable. They can be used several times. You can inject contrast through there. You can withdraw blood through there. What you can do is you can inflate. So they will dilate channels, but they will make room for a balloon. And if your microcatheter goes, then typically your 1.5 balloon or 1.25 balloon will also pass. They do require good guide support for optimal engagement, several uses, wire exchange, distal delivery of contrast, channel dilation, and specialized microcatheters. So this is a family of microcatheters made by a company called Teleflex. This is what we have in our lab, though we also use the Mamba by Boston, and we also use Corsair. But you can see that the top 2 ones are the classic Turnpike and the Turnpike LP. The LP has a lower profile. The Turnpike Spiral has an extra nylon coil on the outside for greater grip. It's only used for antegrade. And then you have the Turnpike Gold, which has a little gold tip. And that metal tip allows you to have deeper penetration. It's like a screw that drives itself in. What makes these catheters interesting, I think, is the construction. Amazing, again, when you hold a catheter, it's so small, but if you look inside, there's actually 5 layers. So there's a PTFE tube on the inside, that's the yellow one that keeps the wire free from the catheter. So as you rotate the catheter, the wire does not move. Then you have the braided sort of tube there. On top of that, you have the 2 nitinol sort of what you call coils, and these coils are the mechanism. So as you start turning the catheter, the coils either expand or they tighten up and they push against each other to push the catheter forward. So no matter which direction you rotate in, the catheter can only go forward, and that's the beauty of this catheter or this system. And then there's a polymeric coating on the outside which keeps it free of friction and isolates from the vessel wall. How to get the most out of your microcatheter? Adequate support. The guide must be well engaged. If the guide is not well engaged, go ahead and use a guide extender. The wire should be advanced far enough. You have to be on the stiff part of the wire. Alternate between clockwise and anti-clockwise directions. If you're using a torqueable catheter, obviously it doesn't work if the catheter is not torqueable. Do not over-torque. I think if you do that, there's a problem with the tip might get stuck and get frayed or break apart. And watch out for catheter fatigue, where the catheter can actually pretzel, and we've had cases where there's septal branch injury from this. Now, some of the specialized microcatheters, this is the dual lumen. The one on top is called the Twin Pass. That's also made by Teleflex. And the one at the bottom is called the Sasuke. It's by Asahi. So these are both catheters which allow 2 wires to go in at the same time, and there are various uses for these. And this is just some of the uses where you can use. So you can use subintermal anchoring technique. You can use it for reverse wiring. You can use it, for support when doing side branches, staying within the stent struts, and so on and so forth. So there are multiple uses. for this catheter, and we always seem to be sort of using them in one way or the other, but they're also essential for a good CTO operator. Okay, the angle microcatheters, these are important. You can get the pre-shaped one. There's a passive angling. There's the one at the bottom is called the Venture. It's an old catheter, was taken off the shelf, and now it's been repurposed. You can actually dial the little sort of handle in the back and get the desired angulation. My preference is the catheters on top, and here's a video that actually will play. This is actually, we're coming down a vein graft, a degenerating vein graft, and trying to go retrograde to do a CTO. You can see the wire in the antegrade direction. And here you can see that there's a very sharp bend that we've been able to make because of this sort of 120 supercross. And what's interesting is that I can actually get the supercross to make that sharp bend over the wire. And once the two wires connect, then we can go ahead and complete the procedure. So typically, the wires, the microcatheters, more often than not, you need guide extenders. Again, several brands available, different sizes, 5 French to 8 French. These help overcome issues of guide support, but then they have other purposes also. They may be deep-seated, allow movement of stents without interacting with the calcium through unfavorable anatomy or through tortuosity. And there are also some novel uses, and the one that I use quite a bit is guide extender-assisted reverse cart. And there's a diagram of that in a bit I'll show you. So this is what the typical guide extender looks like. Again, different brands. This is the guide liner. It was the first one out there. The variation is in the material that they use for the tube, the length of the rapid exchange section, the shape of the half pipe. But the graph at the bottom is interesting. What it shows you is that if you are having issues with support, using a guide liner can give you the same support you would get from a bigger French guide. So many of us, we do cases with the radial. So rather than say, well, we're having guide support and try and use something like a 7 or 8 French with the femoral, you can actually use a guide liner. And the deeper you go in with the guide extender, the more support you get. So this I thought was interesting. This is the reverse cart technique. Basically what this means is when you do reverse cart, you're coming retrograde. Oftentimes the challenge is trying to make the two channels in the antegrade and in the retrograde direction connect. And as you can see here, the wire is in the subintimal space. But if you extend the guide extender, then it makes a channel, and the wire has is more likely to go into the guide extender. So it becomes like a sort of a false lumen, or actually a lumen for the wire to get into, and that way you can complete the procedure. And here's a cartoon that shows that principle. And this makes the reverse cart procedure much easier than trying to get the two wires to connect. Okay, trapping devices. The classic technique was to use a balloon inside the guide to trap. But nowadays you actually have guide extenders with trapping balloon on them. This is again called the trap liner. It's again very functional. The only company that makes this is Teleflex right now. Boston has something called a trapping balloon. You can use it multiple times, and the balloon is such that when it's hubbed out, it stays within the guide. It does not extend beyond the guide. Re-entry devices, we don't use as much of these anymore. I think, at least me personally, I use different techniques, but sometimes when you're in the subintimal space, close enough to the true lumen, you're trying to get back in, this is what you use. This is called the Stingray system. The catheter at the bottom is actually, let me change this way. So the catheter at the bottom, this is to make a channel for the Stingray. This is Stingray balloon. The balloon has two sides, and each side allows the wire to come out in a different direction. And here's a case I'm going to show you. This is an interesting case. This is a stent that seems to be sticking outside the artery. Probably someone put it in a dissection plane. This is a CTO that we did. And again, to cross it, we got into that stent with a crossboss. We confirmed our position. You'll see that we advanced the crossboss through the stent. And once we're there, again, we confirm our position. We're now overlying the artery that we want to enter. This is not a place where we can do Carlino. This is the Stingray. We again test our position just to make sure we're in the right place. And then we pass the wire, and the wire enters. You can see that the wire is sticking outside the dots. It gets into the true vessel. Confirm our true lumen there with this. And you can see this part is excluded because we're outside. We're extra plaque there. And here's the final picture. You can see that we've completed it. We've crushed the stent there. We've reconstructed it, and you can see some of that is excluded. Anyway, this is how you use the Stingray. There are some newer re-entry devices. This is called a Triumph catheter. It should be out, at least in the US, in the next 6 to 12 months. This actually has 6 exit ports in different directions, so you can do the same thing with the Stingray, except in 6 different directions. In fact, it has a second lumen, so you can aspirate from one lumen and advance the wire through the second lumen, so that if you're forming subintimal hematoma, you can actually extract that. Imaging tools are important, include IVUS and OCT. The OCT sometimes is difficult for CTOs. Imaging allows identification of the proximal cap, identify that. It helps the operator understand the anatomy of the CTO once you've crossed, whether you're interlumen or not, whether you need plaque modification or not. And it helps with vessel sizing and optimal stent deployment in CTOs. Now, this is something interesting. This is a paper from about 2 years ago where they used sort of real-time IVUS to redirect, sort of 3D planning of crossing, and this was something that failed in the past, and they used IVUS to basically identify the false lumen, and they have a technique for where they make the wire into a little bend, and you can have you can reorient the wire, and you can use IVUS to change the orientation of the wire and go towards the side branch, and then enter there, and then use that, and this is what they did. So anyway, the paper's on there for you to look at. Okay, snares, sometimes when you come across, you can't make the channel, you have to come out, you have to externalize the wires, you have the large snare, the end snare, and the one snare. Sometimes you come retrograde, you have to snare a wire within the coronaries. For that, you have the micro snare that you can see in the third panel. And obviously some other tools that you need. You've got to have tools for managing complications, pericardicentesis kit, very important. Sometimes you have perforations, you need vascular occlusion devices, coils, gel foam, etc. And here's a case of a perforation there at the distal tip, and here's the coiling to close that. And then obviously covered stents, and you know the Joe Master is what we used to use. Nowadays we use a papyrus. Again, it's highly deliverable. And you can see that there's no stent on the outside, the stent is on the inside. Finally, this is what the CTO toolkit looks like in action. This is the case of an anomalous RCA. You can see we had to come retrograde through an occluded graft. The patient does not have a graft. And just to show you at the peak of the case, at the height of the case, this is what we had. We have our first guide. We have the guide extender halfway down this occluded graft. We have this wire down for support down into the PDA. We have a second wire. You saw how we got back in retrograde. The second wire going up to the microcatheter, that's number 4. This is externalization wire number 5. Then you have a second guide. Then you have a snare. So this is what a sort of a complex CTO case looks like. This is what we started off with, and this is what we ended up with, a nice sort of result there. You can see part of the graph right there. And finally, I think, you know, it helps to have a CTO cart. You know, I think if you especially work in a place that has multiple rooms, and if you're moving the cart from room to room, sometimes I don't know which room I'm working in. So the CT cart has loaded with all of these supplies. You can see all the wires are loaded in one sort of a cabinet or drawer there. Oops. Oh, let me go back forward. Now how do I go back? Well, that was CTO card, you saw it. Achha. So, conclusions. So the CTO toolkit has grown exponentially over the last 2 decades. CTOs are a real thing, they're here to stay. It's not like a fad. Everyone's doing them, and I know they're doing some great work in Pakistan too. Several choices for each type of category, but you don't have to have all of them. You just need to have 1 or 2 in each category. The CTO operator should commit to become experienced with 1 or 2 devices. There are several options for learning. So there's online tutorials, there's proctorships, there's formal training programs, but ultimately nothing, sort of compares to practicing and doing it with other people, with experts, and getting good at it yourself. Important to have the tools to manage complications. Don't get into a CTO if you don't have the tools to do the complication management. And finally, a mobile CTO cart can help keep the lab organized and maintain the workflow. That's it.